Let's talk about the progression of treatment. In other words, you start out maybe diet and exercise. Then you move on to an inexpensive oral drug. Then you move on to something else. Is that based on maximum dose failure?
No, actually, it depends on what the practitioner does. But most guidelines recommend not waiting to max out the dose because the different drugs work by different mechanisms of action. So it's actually very appropriate to use different drugs without maxing out any specific drug and just to have the benefit of different drugs working by different mechanisms and addressing different pathophysiologic.
But you know what I hear from payers is, look, you haven't really reached the maximum benefit from therapy A. We're going stepwise here. So don't start B and don't tell us to pay for B before A has reached the end of its rope. You hear that, don't you?
Yeah, I think all insurers approach it differently. Some just require a step through a particular group of products, so you might have to try and fail. Obviously, you have to try and fail metformin as a first line. That's pretty standard across the board. But perhaps if you want to use a GLP-1, which is another injectable, although an oral just got approved or is about to get approved, you may have to step through another oral before you get that. I'm not sure plans always push, though, to max dose for all of these. I think it's more try a drug from that category. If it works well, great. If it doesn't, you can move on, try another category. But clearly what plans are looking for is kind of a logical approach through what they put together as their preferred formulary that are the most cost-effective options and work through it that way with the patient.
But providers, it seems to me, don't work that way. You correct me if I'm wrong. The insurance companies want to go, there's A, there's B, there's C. It's a very accounting-friendly kind of way of dealing with this. But you guys are dealing with a plastic disease that's always changing. How do you do it?
Yeah, I mean, we really have to go with the patient's profile and how the patient is progressing. We're very fortunate that we have these new drugs, but the cost is still a factor. And we really go very methodically what a given patient needs on top of metformin, let's say. And now we have more and more data, actually good trials, evidence-based for the past 4 years, which dictate to us which patient should get which drug next. We didn't have that until 4 or 5 years ago. Now we have.
Well, there's a lot of support from the plans, I think, for the cardiovascular outcomes trials with these products as well. So we're allowing and promoting those drugs as valid options. But what happens is we're also trying to balance the cost side of the equation. So if we have 4 drugs in a category, we're choosing 1 or 2 that are most cost effective for the plan. The challenge is the plan down the road may have 2 different products that are the most cost effective for that plan because of competing contracting and other things.
And that makes it very difficult for us on our daily life, absolutely, even including insulin. 1 year we are using this particular short-acting or rapid-acting insulin. Next year we'll be asked to switch it to something else, depending upon the patient's plan. So this is another enigma which I would like to see solved in the future.
Look, I'm being very naive, I know, and I'm doing this on purpose to just cause trouble. But why should cost impact a treatment plan for diabetes? I mean, why? We have these drugs, people have insurance. This is a life-threatening and life-changing disease. Why do they have to change insulin suppliers because the cost changed? Why can't we just say, you've got diabetes, here's the medically approved plan, we'll pay for it?
Well, the challenge is we have limited resources. We don't have unlimited dollars, and we're only talking about diabetes at the moment, right? We're not talking about cardiovascular disease and COPD and asthma and everything else. So it's really a challenge for a formulary manager and health plan to try to manage all those costs because we have limited dollars. You know, we have our premiums we charge. The employers don't want to pay increased premiums. They say, wait a minute, your premiums are going up, so what do? You adjust the benefit. So now you've got a drug benefit that had a $20 copay last year for a preferred drug, and now we raised it to $30. Why? Because the employer says, I can't afford to increase my premiums. What can we do? Well, we can change the drug benefit. We can change the out-of-pocket for the patient. And then it's just kind of a vicious spiral, and now you've got a patient who was paying $300 a month for drugs last year, and because their plan changed based on their employer's choice, is now $400 a month or $500 a month.
That's not insignificant. You know, between $400 and $500 is $100, 25%.
Absolutely.
That's huge.
And we heard Helena say we've got these patients on 8 or 9 drugs for different things.
And take a look at the payer population. You're dealing with an aging population, many of whom are now on fixed incomes, sure, right? So either they've got a plan with insurance or they're, as you say, they're on Medicare. those fixed incomes aren't all that elastic when it comes to healthcare costs. And yet their disease is real, it's there, they can't avoid it. What do you do?
Absolutely correct. I mean, as a plan, you try to work cooperatively with the patients. You try to find assistance programming where appropriate. You try to match the patients up with better benefits if they can. For Medicare, you've got supplemental programs. They can get supplemental insurance, and that helps cover the cost of copays. That's very helpful for some of those seniors that are in multiple drugs. The other advantage is if they do spend enough money and they make it to the catastrophic piece of the benefit for Medicare Part D, then they get some significant price relief. Because very often when you get to that level, if a plan is using copays rather than coinsurance, they pay us $6 for a generic and maybe $12 for a branded drug. So they get all their drugs relatively inexpensively until January 1st, when it all resets again. And now they got to make their way through
That's
the
the point
benefit.
I was making. Yeah.
You'll forgive me, but my eyes turn into helicopters just thinking about this sort of thing. And somebody who's 70 years old, worked all of his or her life, just wants his or her medicine, has got to jump through hoops. That means your office is probably on the phone.
Absolutely.
Doing what? Getting exceptions?
Prior authorizations.
Prior authorizations.
Even sometimes writing additional letters and, talk about a cholesterol drug. Some people can't tolerate statins, for example. Now, try to get them a PCSK9 inhibitor. That's the extreme example of how expensive the drugs are, besides insulin.
Sure.
In my practice, we dread January 1st because comes January 1st, people's insurance changes, the benefits change, and all of this sudden drug A that was approved and doing a great job with a reasonable copay becomes out of reach, and we have to start either going through pre-authorization, which is very time-consuming and not always successful, I have to say.
How many folks in your office spend all day long phoning
I
for
have
prior
one
auth?
person.
You have
I have
dedicated
one
employee.
person,
What
yeah.
about you?
Same thing. We are in a large group and we have several people working on this. But in addition to that, we have to look over everything and we have to write letters. And that takes additional time.
Now, if I were to say that there is a healthcare cost to the personnel and man and woman hours involved in trying to get prior authorizations on January 1st, is that figured in by the plans?
Well, absolutely. And we have a lot of benefit changes at the first of the year, formulary changes the first of the year. So we have the same problem. Right? We have a lot of staff resources used. And one area we can move positively in would be to move toward electronic prior authorizations. Not all prior authorizations are electronic. The number one reason they get rejected is the information isn't complete. It's not that the patient wouldn't qualify, it's that for whatever reason, as it was filled out, something was missing. And then it has to obviously come back again. But if we had electronic prior auth, just like when you're trying to order something on Amazon, if you don't check the right box, it tells you right away, hey, hit this button, and you clear and you get it through a lot more quickly.
All I know is I hear this all the time. The people apply on paper, and they get some anonymous person with a green eye shade and a little thing on his arm or her arm saying, "Excuse me, sir, you forgot page 132, subset A, paragraph 2, paragraph 1, line 3. Rejected." Now that's crazy.
Well, it's crazy, but in theory, the criteria are very specific, and if the patient doesn't meet the criteria from the plan's view, then they would be a candidate for something else. Okay. So they're trying to make sure that this patient clearly is an appropriate candidate. If we look at the GLP-1s, they have weight loss as a benefit, if you will. But what if a person doesn't have diabetes and wants to use a GLP-1 for weight loss? Well, the plans don't want that. So the plans put a prior authorization in to say, does the patient have diabetes? That's like question number one. If they do, okay. Then they're going to be okay with them using a GLP-1, provided that they've tried something else first, so they don't go immediately to those because they're more expensive than the insulins in some cases. So they're trying to work their way through, cost-wise, logical steps, trying to spread the value across the benefit as best they can, but not have somebody jump immediately to the most expensive, latest, greatest therapy in the mix.